Okay, so thanks for coming out this evening. I think hopefully this will be a very educational event for everyone. I think this is a great partnership we have between the Arthritis Foundation, which is a great not-for-profit organization, which, as you've just heard, is really helping a lot of people of all ages. My practice is Performance Orthopedics in Boynton Beach. Conformis is the company that helped also sponsor this event, which is, I think, amazing technology that I'm going to spend a lot of time speaking about tonight. And of course, our Orthopedic Institute here at JFK is something I'm very proud of. We've got a specialized 36-bed unit, all private rooms, all orthopedics with a specialized gym that we really are proud of, and we've obtained this certification that no other hospital has really on the whole east coast of Florida from JACO for hip, knee, and shoulder replacements. So we've got a lot to be proud of here, and tonight we're going to spend a lot of time highlighting some of these technology advances that we have and that we're implementing here at JFK. So I always like to start by asking everyone, does anyone in the room know what's the leading cause of knee pain?
Arthritis.
What kind of arthritis?
Osteoarthritis.
Okay, good. Osteoarthritis is right up there. Yeah, so any type of arthritis can cause problems with joints. The most common thing that we see is osteoarthritis, but as you know, there are rheumatoid arthritis and all these other disorders that can affect children and all people of all ages. But osteoarthritis is a mechanical condition where just the cartilage in the joint wears, similar to like the tires on your car. If you drive your car, well, your tires wear, and your knees and your hips and all these other joints are no different. So the cartilage wears out. It's not a systemic disease. It can happen in one joint. It can happen in multiple joints. And we don't really know what causes it. There can be multifactorial. There can be a genetic component. There can be a weight component. There can be an activity component. So there's a whole host of things that can lead to this common pathway of osteoarthritis. So what does this look like in the knee? Well, it's basically the knee is usually shiny, this sort of joint substance which is very shiny, like the end of a chicken bone. You see the shiny cartilage. And that's soft and spongy. And when that wears out is when the joint becomes painful because the bone touches the bone. Cartilage doesn't have nerve endings, so when it touches itself, you don't feel it, but bone does. So when that cartilage wears through, the nerve endings get stimulated and you feel pain. There can also be inflammation associated with that as well. And what does this lead to? Well, it leads to pain, stiffness, difficulty functioning, and at the end of the day, it interferes with your quality of life. And that's where the real problem comes in. I tell everyone this is not like brain surgery here. It's orthopedics, and it's pretty straightforward. So I really like to spend time in my office showing people what the problem is. And you can see on these X-rays right here, on the left side you see a normal-looking knee. So you've got a nice preserved joint space. It looks pretty symmetric on both sides, and it shows up as space because cartilage doesn't show up on X-ray. So you see the bones here, but this space is actually the cartilage of the joint supporting the joint. When we look at this side on the right here, you can now see that the inside of this knee is narrowing, so the cartilage is wearing thin there, and that's what osteoarthritis looks like. So this slide shows three different views. I always usually take 3 or 4 views of people's knees because there's different things you could see. And when I look at a knee, I like to think of it as 3 little joints within that one joint. Because there's a medial side, which we call the medial compartment, the lateral side out here, which we call the lateral compartment, and then there's the patellofemoral joint, which you see from the side, which is basically the joint behind the kneecap. So just really remember that there's 3 little joints within each knee, and that's an important part of this lecture. So the first thing is, when I tell my patients is, don't rush into surgery. I see patients all the time that have seen a doctor who says, oh, you need a knee replacement. And it's kind of one of my pet peeves. You really should be the one who decides when and if you need surgery. It's not something that a doctor should decide. Because there's some people who have very severe disease that play golf and tennis and have no pain, and we don't understand it. But they shouldn't get surgery. If it's not interfering with your quality of life, you don't get surgery. We don't operate on X-rays. We operate on people. So that's a real key point. When the pain gets to the point, or the limitation of function gets to the point, well, that's when you're going to decide, hey, I need to do something about this to get my life back. And that's when it is an elective procedure. So there's not really much harm that's going to come from waiting, other than really pain. And if the pain's not there or the limitation of function's not there, then don't consider surgery. The other thing is do everything to avoid surgery. I mean, I usually don't even speak to someone about surgery unless they've tried numerous things to really take control of this with less invasive means. And the first two things that I always talk about are exercise and weight loss. And those kind of work hand in hand. Exercise and strengthening the muscles is so key because if you have strong muscles, they support your joint, whether it's healthy or unhealthy, and it can take force off the joint and it can make the joint feel better. So it's really important. That's where exercise comes in. What kind of exercise? Well, find something you like to do that doesn't hurt your knee and do it regularly, whether it's a bicycle or an elliptical trainer or walking or swimming. But you have to do it, and it does work, but you have to be disciplined about it. The other thing is weight loss. Your knee sees 3 to 4 times your body weight with normal activities. So a 10-pound weight loss can lead to 40 pounds off of your knee. And that can make a big, big difference. So those are the first two things starting out. When those things are not enough, well, that's when we start to think of, well, what kind of drugs can we try? And, there's some simple things like Tylenol, which is a relatively safe drug as long as it's not taking too much. And then there's anti-inflammatories, like all these things over the counter, like Aleve and Advil. And then there's all the prescription anti-inflammatories. And there are numerous ones like Mobic and Celebrex and all these things. And some of them, yes, were taken off the market, like Vioxx and Bextra. And then, some of them, like Celebrex, are still on the market. That kind of, when they started out, we were really excited about them. And then we learned, like every other drug, that there's some risk to them. But that's okay as long as that risk is managed appropriately and the benefits outweigh the risk. So every situation is individualized. And the main thing is just, discussing it with your doctor. How do these drugs work? Well, the anti-inflammatories decrease inflammation, they relieve pain. Now, they can cause gastrointestinal problems like bleeding and ulcers, and that's where the limitation comes in. And also now we're learning there's some cardiovascular effects, so people with maybe bad heart disease should be on these things. And you can stay on these things long term. I mean, there's some people who are on these their whole lives and do it relatively safely, but it should be monitored by your primary care doctor. And you alert them to the fact that you're taking drugs when they're new. Glucosamine, chondroitin, and all these products you see at Walgreens and CVS and everything, there's a whole shelf full of them. And we get these questions all the time, well, do these work? Well, unfortunately, I think the answer is they probably don't work all that well. The National Institutes of Health did a study a couple of years ago called the GATE analysis, where it was supposed to definitively answer the question whether these things work. And really, by and large, they didn't really do what they were thinking would happen. They really don't regrow cartilage, they don't support the joint space, they don't thwart the progression of arthritis. In a very small subset of people, they did provide some pain relief. But for most people, it didn't even provide pain relief. So by and large, it's probably not a good way to spend your money on these products. The next thing that we try is injections, and there's 2 types of injections that we give. The first is corticosteroids, like cortisone is the common name, but we have all these different varieties. And these actually crystallize in your joint. They give you temporary relief. They probably last on average 2 to 3 months. And they can be a long-term option. I mean, cortisone has a bad name in the community. People are so scared of it. And yes, if you take oral cortisone pills like prednisone for long periods of time, it can have all kinds of weird side effects. But by and large, injections into joints are pretty well tolerated. Sometimes in diabetics, they can raise the blood sugar. But most people tolerate these fine. And as long as you're not giving it all the time, it's probably not going to degenerate your tissues and tendons. And even if it does, I mean, most of the time we're injecting these into joints that are already degenerative. So as long as cortisone works, I think it's a great option. When it doesn't work, sometimes we try these other things. They're called hyaluronic acids. Synvis, Zipart, Hyalgan, Euflexa, Orthovisc. There's a bunch of them. And they're all pretty similar, and they work by lubricating the joint, and they probably have some anti-inflammatory properties too. And it depends on the product. Some of them are 1 shot now, some of them are 3, some of them are 5, and usually get 1 shot a week for however many weeks. They're not a cure, they're not going to regrow cartilage, they're not going to do anything amazing. But for a substantial number of people, they do give some good pain relief. I'd say it's somewhere around 50 to 60% of people get relief from these things. And when they do get relief, it tends to last. I see it last anywhere from 6 months to a year. So I do think it's a good option for a fair amount of people, and it's something worth trying. You really don't have much to lose from time. They're usually pretty well tolerated with a minimal side effect profile. The other thing that we talk about a lot is bracing. So this is what's called an unloader brace, and I'm going to allude back to that part, how there's 3 different parts to the knee. Well, if only one side of the knee is worn out, sometimes you can wear a contraption like this, and it can actually open up that space by stressing the knee and loading the other compartment. And that's what's called an unloader brace, because you're unloading this compartment and starting to put some stress on the other side. And that's they actually can really help a lot of people. The problem is compliance. A lot of people don't want to wear a device like this, especially down here in Florida where it's hot, and they're not usually well tolerated. But it is a good adjunct in somebody who's really looking to avoid surgery or can't have surgery, or is just not happy or not at the point where they need it, but they want some relief. So something that we always consider as an option with people who have disease of mainly that one side of the knee. Arthroscopy is the next thing, and this is something that I have pretty strong feelings about. I think it's probably a procedure that is still, to this day, completely overutilized in this country. I'm constantly seeing people in second opinion who have an arthroscopy, they don't get better, and I take a look at their x-rays and they're bone on bone. And it's no mystery to me why they didn't get better. They didn't have the right operation. You know, the arthroscopy is a good operation if someone has a meniscal tear, meaning that there's these rubbery cartilages in the knee that can rip and tear, and they can cause mechanical buckling of the knee or giving way or even pain. But if the knee itself and the underlying joint cartilage is worn out and the bone's touching the bone, the meniscus is irrelevant, and you should just ignore it. Don't even waste your time thinking about the meniscus, because it's not going to work. And that's been on the front page of the New York Times and Wall Street Journal and everywhere. But surprisingly, it's still commonly done, and I think it subjects people to the risk of surgery sometimes without any benefit, which I never think is a good thing. But in a case like this where you've got healthy cartilage, you know, and there's the meniscus right there, well, if there's a well-defined tear, you know, usually you can come in with an instrument like this and just shave out the tear, and the underlying joint is healthy. And arthroscopy is a great operation. It's minimally invasive and has a role. Just like any operation, it needs to be in the right patient.